antidepressants in the water supply, constant videotaping of everybody. Can you hear me back there? Are we okay? Volume? Okay. Volume? Dead zone? Good? Good? Okay, great. All right. Okay, so a little follow-up on the exam. They're just got the final exams from around the campus because, as you know, different people took it at different places. So we're going to, hopefully by tonight, probably late tonight, we'll have the scores, your grades posted. What I do, I've been teaching this course for a long time, and I know the average score over 10 years for all the midterms. So whatever the final score is, if it's above that average score, then we're fine. If you guys, your overall class is below the average score, let's say by 5 points, everybody gets 5 points to bring it up to the mean. So I just moved the whole thing. So we're kind of targeting a pretty strong B as the average. So they'll be adjusted. It also means if you got 100% on this, you got 100 on the exam, and it's a 5-point differential, you'll be recorded as 105, right? It's not like you're going to be capped, okay? Just so you know. All right. So what else? Is there any other technical things, guys, that we need to go over? No? All right. What? All week. Okay, so there's no sections next week, but I have office hours next week. Do you have office hours? They have office hours, but not sections. Okay. All right, so we're making a big transition now from the methods part of the course, and I think you got a good feel for all the various tools you have to evaluate nervous system function both in health and in disease. And at this point, we're going to switch into the disease part of the course, which is probably, for most of these, going to be a little bit not as complicated. It's more trying to remember organization of what's a stroke and what causes dementia and so on. But before we transition and start today on stroke, I thought I'd have a little break point. So how many of you people know David Letterman? Okay, fantastic. How many of you know stupid pet tricks? Stupid pet tricks. What's your favorite stupid pet trick? They're pretty funny, right? they're okay. Anybody else with stupid pet tricks? Okay, I like most of the stupid pet tricks, so I thought as a transition, I'd show you one of my favorite David Letterman stupid pet tricks, particularly since in the last lecture we talked about coma. Okay, it should be on. It is on. It says Extron, speakers. What's going on here? That's on. All right. Try it again. No. Okay. Colin, Nick, help me figure out what is up with this. It's not the connections, I don't think.
Try now.
What did you hit?
This was muted.
That'll do it. Operator error. I had the mute button on. Thank you very much, Colin.
Well, try it and make sure that actually works.
You don't believe in me? All right, fine. Here we go.
I'm a skeptic.
David Letterman.
Bailey, and what are you guys going to do?
She is going to play dead.
Play dead? And then come alive, it says here.
Yes.
Play dead and come alive? Okay.
Yes.
Do you need that other devil dog out here to help?
No.
How was it? Were you backstage with that crazy dog? How was...
He was calm.
Oh.
Until he gets the command.
Yeah, until he gets the command.
Yes.
Hey. Somebody ought to look into that guy. Okay, Bailey now. Bailey will play dead. What do we need to do here? Anything, Mike?
Nothing.
Okay.
Okay. Bailey, play dead. Hey. Play dead.
That was good.
Iconic.
Play dead.
Oh, man.
All right.
Yeah.
There you go. Pet trick. I have more. Did you like that one? That's not bad. One of my favorites is when they bring out the pit bull with the guy who's got the ponytail and he's a logger, and they bring out a tree, and David Letterman says, "What's the dog's trick?" And he takes the dog off the leash. The dog jumps up and starts ripping limbs off this massive pit bull, and basically denudes the tree. I mean, it was pretty funny. All right, switching course. Clinical stroke first. Again. Let's just do this because I think it makes it more salient. How many people here know somebody, a family friend or family member who's had a stroke? Look around the room. Just do yourself a favor and look around the room. Okay, great, fantastic. So more than half the class. So we're going to learn about the causes and what you should do if someone has symptoms. I'm not going to go into pediatric or kid or early adolescent stroke very much, but I will bring in some aspects of it. The first thing I want you to understand is what is a stroke? A stroke simply means that you've cut off the blood flow to a piece of the brain. It is pathologically exactly the same as getting a heart attack. Blood flow in your heart muscles, no difference in the pathology. They both have abnormal blood vessels, usually atherosclerosis, right? It's just that one knocks off blood to the head, one knocks off blood to the heart. So now I want you to imagine a lawn, okay? It's a nice lawn, and it's got sprinklers everywhere. There's two kinds of strokes. One, as you can see up here, is ischemic stroke. Ischemic stroke means the blood vessel closes off. It's clogged. The other kind of stroke is hemorrhagic. That means the blood vessel actually burst and blood flowed out of the blood vessel. So now go back to the lawn analogy. You got your sprinkler heads. You go away on vacation. You come back. You could have two kinds of stroke to your lawn. One could basically be the sprinkler head closed off. It got clogged. And you'd see a big brown piece of lawn. That's an ischemic stroke, and that's what happens in your head. Not enough flow, tissue dies. Or a sprinkler head could have broken off, and you have a squirt of water shooting up in the sky, which is probably all over the lawn in an area, and probably so much water that it might have even killed the lawn just from having no oxygen from the water. So those are the two kinds of strokes. And you can see clogged vessel is number one, and then usually clogged vessel is older people, although you can get clogged vessels in young people. And I'll just give you one example. 7 miles from here, we have Children's Hospital. Let's say you're the pediatric on-call person, and you go into the emergency room, and it's a young African-American kid who all of a sudden has a headache, and basically they're not moving their left side. What do they most likely have? 10-year-old, 9-year-old, 11. What do you think they have? Sickle cell disease, exactly. Sickle, it's a genetic problem where your cells tend to sickle, and as they sickle, they tend to clot, and you can clot in arteries and veins. So that's a relatively uncommon cause of stroke, but I can tell you this, it's a common cause of stroke if you have sickle cell disease, even if you carry sickle trait, not the full double for sickle cell. So, but most of the strokes, the thrombotic strokes are due to atherosclerosis, and I'll show you exactly what that is. And then some are from heart disease. Now, heart disease means the most common cause would be someone's had a heart attack and they've got a partially damaged heart wall and clots form on it and go up to the head. And we'll talk about that in more detail. But you can also be a young person and have a valve problem or a few other heart abnormalities, and you could have the same problem. So you could have a 20-year-old presented out the baits with left-sided weakness, and if it's a 20-year-old acute onset, you're thinking there's a heart problem. Could be some other odd coagulation problem, but that would be at the top of your list. Okay, so embolic strokes, which means they start in one area and end someplace else and lodge in the vessel, basically can happen in any age group. So here's a picture here of a thrombotic stroke. Here's a big artery in your neck, your carotid artery, which you all know is sitting right here. You can feel it easily pulse, for those of you who like to feel your carotid. Whenever you're feeling blood vessels, use your fingertips. And don't press, just get in there. Yeah, that's your carotid artery. It's a common source of getting atherosclerosis. Atherosclerosis basically means damage to your blood vessels from cholesterol and other things building up, usually, and I'll show you some of the things that predispose you to happen there. Now, what you can see here is there's a clot. That vessel's completely shut off. You can imagine if you completely shut off your carotid artery, you got big-time problems. You're knocking out 80% of blood flow to one whole hemisphere. And basically, then you have an embolic stroke. That could be from the heart. You notice the blood vessels are clean. Let's say it's the 20-year-old in the hospital, in the emergency room and out the baits, and you could see a clot formed in the heart, and it traveled up the blood vessel, and it got stuck right there. The blood vessels look good, but an embolus landed there and did the same thing. It blocked off the blood vessel. Totally different causes, but the same net effect. A blood vessel got clogged. And then there's a hemorrhagic stroke, which is quite common, particularly in people with poorly controlled hypertension. And if you're going to do anything when you go home on a vacation, ask your parents what their blood pressure is. And if they don't know, tell them to figure it out. Because you don't know you have high blood pressure often. That's why they call it the silent killer. There's no symptoms unless it's way high, but it can be high and contribute to problems. Here's a hemorrhagic stroke. The ischemic stroke killed blood flow, and this whole area of the brain slowly dies. The hemorrhagic stroke popped, the blood vessel burst, and there's actually extravasation or blood entering from the vascular supply, the arterial supply, and ending up in the brain. And we'll talk about these in a bit more detail. You need to know about the arteries of the brain. The big one perfusing most of your hemisphere is your middle cerebral artery. And there's only three arteries you need to know. The anterior cerebral artery gets the front part, polar part of the brain. The middle cerebral artery gets most of the hemisphere, about 80%, and the posterior cerebral artery gets the back of the brain, right? The visual areas. There's the posterior cerebral, here's the anterior cerebral, and there's the middle cerebral. These are the three main blood vessels, and we'll get, at the end of the lecture, it's gotten remarkable, just in the last 10 years, what the invasive interventional neurologists and radiologists can do. You can actually thread a catheter. Let's say it's that 20-year-old in the Alta Bates emergency room. And you know she's got a clot in her middle cerebral. You can thread a catheter up into her middle cerebral, put a cage on the clot, and extract it, and get sometimes complete recovery. It's really quite amazing, the interventional things you can do now. And I just read an article 2 days ago. It used to be you don't want to give clot breaking up drugs after 6 hours. They've now extended it for pulling clots out of people's head to 24 hours, showing improvement. So the whole field is rapidly changing. The key thing for you to take away from all this in some ways is a brain attack should be treated like a heart attack. Okay? What do I mean by that? If you're at dinner with your family and your grandfather starts going, oh, chest pain, I'm having trouble breathing, everybody's going to say, heart attack, get him to the emergency room, right? It's going to happen. But if at that same dinner, your grandfather all of a sudden starts having word-finding difficulties and can't move their right hand, that's the same kind of blood vessel being closed off that could lead to a stroke. They should get the same emergency treatment and go right to the hospital. The faster they get there, the more likely you are to salvage tissue, and that's the end game. Save as much brain tissue as you can. So here's the undersurface of the brain. Here's this beautiful posterior cerebral artery, and this is the part of the brain that gets your visual cortex. Remember we talked about that. If you had an infarct here, you'd lose half of the world. You'd have a hemianopsia, and so on. So these arteries beautifully match all the major behavioral syndromes, and as the course unfolds, we'll get better and better at linking them up. Now, the risk factors for stroke are pretty straight up. Poorly controlled hypertension, cigarette smoking, diabetes and high cholesterol, overweight, no exercise, and then genetics, which is a harder one to control for. But if you look at this list, guess what? You can control all 5 of those, right? You can. You can control your blood pressure. You can control your diabetes. You can lose blah, 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 right? They're all controllable. So these are really get into the more tricky issue of getting people to change long-standing behavior, right? The habits they have about what they eat, etc., how they treat their bodies. All these things become the domain of the doctor who can get control of the patient and make the patient understand that this is going to have a long-term effect on all kinds of aspects of their life. They don't want to have a stroke. Genetics is, of course, you can't control your genetics. That accounts for a relatively small number of the roughly 450,000 strokes in the United States last year. That's a lot of people. Did I see a hand up somewhere? Or am I? No. Okay. All right. So these are risk factors, very, very important. So what happens if let's say you have high cholesterol and poorly controlled hypertension? 2 risk factors. And this is your blood vessel. This is your nice, smooth blood vessel with a nice, smooth wall. What happens is a cross-section through you just think of the blood vessel as a pipe. What you start getting between the inner lining, epithelial lining of the blood vessel, you get deposition of bad stuff. You get immune activation, cholesterol deposition, platelet aggregation on the wall, and as it gets worse and worse and worse, you slowly really begin to close off the blood vessel. So you can see here, and it often occurs at where arteries have bifurcation points. So there's an engineering component in terms of blood flow and turbulent flow at those kind of junction points. And this is an early case. There's some cholesterol. I just tell you, sadly, if there's some kids who have died of accidents and they've looked at their blood vessels, there's evidence in some kids of cholesterol deposition at age 10. That's 10 years old. That's a dietary issue. You get more cholesterol in there, it starts to break the lining, which means the lining basically is the lining is broken, and what it does is it attracts platelets, because the platelets they're just floating around. They want to fix things. You're bleeding, platelets, fix it. So they arrive. The unfortunate thing, as they try to fix that lining, they can produce a clot. And that clot could either get big enough to close the vessel off like this, or actually, you could get a piece of the vessel, of the clot breaking off and shooting up as an embolic stroke. So you can either close off the vessel from atherosclerosis, or if it's disease in your carotid, you can actually have clots form on the atherosclerosis, and then a piece will break off. And it's kind of an embolic stroke in that case, because it's from a different space, the neck, ending up in the brain. Now, what we want to do is not let this happen, right? And these are lifestyle changes. And I'll show you what we do if the person comes in symptomatically. There are treatments, and they continue to improve. So here's a patient. This is what it should look like. There's your nice, big carotid artery. Most of you just felt it. Comes up here and it bifurcates, and this is the big one that goes into the brain. Another one goes extracranially. And here's a person who's got a constriction, right? The artery should be that big. This is an angiogram. You can see the constriction. Now, when you get a constriction of anything, you guys have all seen a stream, right? When the water in the stream gets narrow, it kind of bubbles, right? There's a little turbulence right after it getting narrow, and then it flattens out again. That's what happens to your blood flow. It hits this decreased diameter blood vessel, and it actually causes turbulence. And if you put your stethoscope on the person's neck, you'll hear ksh, 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 ksh. Every time the heart beats, you hear what's called a bruit, B-R-U-I-T. And every good doctor checks their patients for bruits, because if you detect it and they're not symptomatic yet, you want to figure out how bad's their carotid and maybe fix it prophylactically, right? Send them to a vascular surgeon and get the plumbing fixed. And so the procedure, stenosis with a bruit, and surgery, take out the clot and remove the cholesterol and try to repair the artery. So here's the same patient, pre-surgery, super risk for closing that carotid off or throwing an embolus with all kinds of misery associated with it, a stroke. And here they are post-surgery. Pretty nice. So it tells you what your surgeons can do to actually treat these things. And that person has a normal blood vessel, and their risk of stroke has dropped, okay? Surgical treatment. There's also medical treatment, and, we use anticoagulants and all kinds of things. So what does a stroke actually look like? Here's a middle cerebral artery stroke. The middle cerebral artery is in red. As I told you, it does 80% of the blood flow. And here's someone who's closed off part of it. And that's all you see. It's a dark signal, right? That's it. That's the acute onset of a stroke. And if it was in the left hemisphere and it involved the left frontal lobe, the patient would probably have a Broca's aphasia, right? If it was in the right hemisphere, they'd have different symptoms. And we'll get into that in more detail as the course progresses. Now, sometimes, I should say, when you get a stroke, what happens to the cells that don't get blood to them? They die. Because if the two things that you need to keep your cells alive in your brain, it's really simple, glucose and oxygen. And when you have a stroke, you lose both. So the tissue dies. As tissue dies, what it does, it swells. The cells get bigger. It's called edema. There's increased water, so you get swelling. And sometimes the swelling becomes so bad and that it can become fatal, because the swelling will get, this one is not that bad. It gets really big. It can actually put pressure on the brain. And in that case, depending on the case, we actually go in and we'll take off part of the skull to relieve pressure. Here's someone who actually, this is a fatal case, where taking off the skull didn't help. And what I think you can see here, here's the normal brain on one side. Here's a big middle cerebral artery infarction here. And you can see this whole, if you look at the volume here, it's dramatically bigger than the same volume here. And that's because there's increased water and swelling and dead cells and edema. And you need to be aware of this. And if warranted, as I said, we do surgery for that. And it can be highly effective. You're going to lose the tissue, but you'll save the person's life. So how about a stroke in the back part of the brain? This would be in the posterior cerebral artery, which comes off right there, comes on back, and that does the visual cortex. And here's a perfect example of an acute stroke in the posterior cerebral artery. You see all that black in the stuff there? That's blood in the cortex, which means there was a little leakage. Not only did the person close off a vessel, the tissue that didn't get any oxygen started to leak a little bit. It's not a big hemorrhagic stroke, but there's bleeding into the infarct. And then you got to be really careful. You don't want to put that person on an anticoagulant because it will not turn out well. They will deteriorate rapidly. But this was fatal, not from this. This stroke would certainly not be fatal in this location. I don't remember the case. They probably had a heart problem and an embolus. I actually don't remember the details. But this is a classic. And if it was on the right side, again, you'd have a left homonymous hemianopsia. The patient looked at that 1034 sign up there, and I did their visual fields. Nothing would be there. It would be all gone. Because the left side of the world goes to your right hemisphere. The right side of the world goes to your left hemisphere. Okay, and this is what they look like chronically. So what happens when you kill this tissue by depriving it of its nutrients that are delivered in the blood? What happens is over about a 6-month period, the brain's natural cleanup mechanisms actually remove all the dead tissue. There's many cells involved. One of the principal ones are macrophages, for those of you, who've done any microbiology. And you can see here's a perfect example. This is a chronic patient. Here's the temporal tip here. And you can see all of this is a big middle cerebral infarct taking out a large part of the frontal lobe. The tissue's just gone, right? So this could be a patient with a chronic Broca's aphasia. Over here, you could see a patient who infarcted their posterior cerebral artery. And the posterior cerebral artery basically supplies this blood flow to the inferior part of the temporal lobe, and even in some cases the hippocampus, memory areas, and it's gone. The tissue's just been resorbed. So that's the final outcome. And of course, when you get these strokes, when you have this kind of damage to your brain, not only do you have the behavioral syndrome associated with wherever the damage is, you've now put an insult to your cerebral cortex, which makes you at risk, as we'll discuss later in the course, for development of late-onset seizure disorders. Right? So you can have a stroke and you think it's over, but it may not be. You may get a seizure disorder from it because you've damaged brain tissue. So you see the acute with swelling, the chronic, the tissue has been all resorbed. And there's our nice olfactory bulbs, typically damaged in head trauma, producing anosmia or loss of smell. Now, we talked about predominantly big vessel infarctions, the large vessels coming up into your head. And that accounts for lots of our ischemic, closed-off blood vessel strokes. But there's another pattern that we see very frequently, particularly in addition to the atherosclerosis in the big vessels, you get in diabetic and hypertensive patients damage in these small penetrating vessels. What do I mean by that? Here's a big vessel coming up, right? You've got a big vessel coming up here, carotid. You're going up here. Here's your big middle cerebral. That would be a big vessel stroke. That could take out a large piece of tissue. But then coming up at right angles to the big vessels are these what are called penetrating vessels. These little, right there. See these little arteries? Each one of those is a penetrating vessel, and they tend to supply the deep brain structures. So they're supplying predominantly the basal ganglia, these deep structures, but also deep white matter. They don't affect the cortex. They affect deep structures. In fact, here's a little, and they produce, instead of big strokes, they produce small strokes, which are called lacunar strokes. Little, and God knows why that terminology actually came up, but it's really because the tissue's gone and it produces a little, if you will, little lake, a little fluid collection there. Now, these can be anywhere subcortically. Sometimes they're not in a critical area and you don't even know you had the stroke. Right? They picked off a little piece. They picked off half a centimeter somewhere, but it wasn't something that produced a behavioral syndrome. So the patient comes in, now they come in with weakness because the next lacunar stroke got their cortical spinal tract, their motor pathway, and then you get overtly weak. You look at their MRI scan and you say, there's 4 other lacunar strokes that we never detected. And this is very typical in people with diabetes and hypertension. And if you throw in some of the other risk factors, these are lacunar strokes. And if you get enough of these subcortical strokes, they actually cumulatively start slowing down your cognitive processing. Just think you're picking off lots of little wiring between areas in the brain, and you can actually result in dementia. Okay? And we'll talk about this in the dementia course. This is a big deal because if you look in the Bay Area, right, just you look within 15 miles of here, you got a private hospital. Let's say Out the Bates, great hospital, higher standard general medical care for everybody who goes there, which means you're getting their blood pressure checked, they're getting their glucose checked, they're getting their cholesterol checked, and their docs are trying to treat it. So you go there and you say, what's the number one cause of dementia at Out the Bates? As we'll talk about later in the course, it's Alzheimer's disease. It's a progressive degenerative problem. Now, you get in your car, and you're the doctor, and you go over to Highland Hospital, which is in Oakland. Does everybody know where Highland is? It's our regional trauma center. You know, if you get in a bad accident, that's where you're going because it's fully staffed all the time. Because that serves a lower socioeconomic patient population. By definition, it means they're going to get not as good primary health care, which by definition means they're going to have more untreated hypertension, more untreated diabetes, more untreated cholesterol, and that means they're going to be more susceptible to get multiple lacunar strokes, which can sum up and produce dementia. So the number one cause of dementia in Berkeley is Alzheimer's. 7 miles away, the number one cause of dementia is progressive small lacunar strokes in people who have not received appropriate medical care. So this is a big deal. Just, you know, if you think of that disparity just in the Bay Area, you can imagine it on both a countrywide and a global basis. So here's just some examples of lacunar strokes. Here's one in the little one in the thalamus. Here's one in the basal ganglia. Here's one on a T2 scan where you see it as white. And these are I can't tell you how common these are. Now, so that's ischemic strokes. Either thrombotic, where the vessel closes off, which is, by the way, your heart attacks are all closed-off vessels. You rarely get an embolus to a heart vessel. But you do get them to the brain, and you also get embolus from the carotid to the brain. Closing off vessels, big vessels, and then, depending on your risk factors, increasing chances of getting lacunar small strokes, which if you get enough of them can sum up to actually produce something that is not something, it produces a dementing type problem. The lacunar strokes tend to be more in the front of the brain, which means instead of presenting with memory initially like Alzheimer's, the patient may present more with executive control problems. But again, we'll talk about that a little bit later when we talk about dementia. So now let's just switch gears and talk about the pop sprinkler head. Yeah?
All these seem to be supplying blood flow. What about the draining veins?
The draining veins, yeah, I wasn't going to cover that, but since you brought it up, it's an important issue. Yes, you can get clotting anywhere in the system, but it's 99 of the strokes are on the arterial side. But if you're at risk, so if you see the sickle cell kid, and they have a severe onset of headache and they're starting to lapse into a coma, right? They may have clotted off their big draining superior sagittal vein, right? Or you could have, there's certain syndromes that everybody is susceptible. Well, not everybody, but some people will or may be susceptible. You get hypercoagulable during pregnancy. So you see an increased incidence of both arterial and venous occlusions in the last couple weeks in pregnancy and maybe the 4 weeks post. So the answer is yes. They're infrequent, but they can occur. You can get venous occlusions. But usually there's a clear cause. That doesn't have to do with atherosclerosis. It has to do with something with a diathesis or a predisposition for your blood to clot anywhere. Okay? Any other questions on? Okay, good. All right, so again, what happens? These little penetrating blood vessels are susceptible to having lacunar strokes, but they really are susceptible to the ravages of hypertension. And what hypertension can eventually do is produce a little aneurysm of the blood vessel, a little stretching of the wall. And if you want to visualize what an aneurysm is, maybe not all of you have seen this, but have you ever seen an inner tube blow up, and then all of a sudden there's one little part that sticks out of the inner tube, and it doesn't look as, it looks like it's lost some of the material. Do you know what I mean? Has anybody seen that? Yeah, maybe not everybody. It means that the wall's gotten weak in the inner tube, right? And it's starting to get thinner and pop out, and it's liable when you're going down the rapids. If it hits a rock because it's thinner, it's going to pop, right? And as opposed to the rest of the thing. So that's what happens in these blood vessels. They get these little aneurysms, and they're being pounded with this high blood pressure, and eventually they pop. They literally pop, and blood flows into the brain, right? And you can see, this is a CT scan. That's a fatal case. That's a bad one. You can see these be quite big, and they push brain tissue away, and they cut off blood flow to some areas, so they have effects both of the pressure of all the blood in your brain, right? The only pressure from an ischemic stroke is if it swells a lot. But as soon as these things happen, as soon as the blood gets out there, you have an instantaneous increase in pressure, depending on how much blood popped out of the blood vessel. And your brain can't take too much additional blood. And the reason for that is, if you get a hemorrhage in your abdomen, and it's a big clot, you have 100 cc hemorrhage in your abdomen from something. It'll hurt. Your stomach wall will expand. You'll live. If you get a 100 cc clot in your brain or bigger, remember, there's no place for that blood to expand. Your brain is, the entire space is controlled by your skull. So at some point, the pressure will go up, and you'll eventually get a point of so much pressure inside your skull that it'll produce a global drop in blood flow to the brain. Okay, so these can be very dangerous because of the rapid onset of blood pressure. Now, the hypertensive ones tend to, about half or more actually occur, as is outlined here, in the basal ganglia. Very, very common source. They can occur in the cerebellum. They can occur in the thalamus. At lesser incidences. The number one is basal ganglia. And here's what it looks like. Okay? You can see here, there's your CT scan, because remember, the patient just came into the hospital. We want to do CT to see if there's blood. Absolutely. There's a big area of hemorrhage sitting right there. It's putting pressure. You can see there's your ventricle. It's actually compressed. And, this patient, if you manage him effectively, could die or not die. If you manage them effectively, they're probably going to survive. And then the blood will get resorbed, and they'll start looking better. Here's a fatal case where it was just such a massive hemorrhage acutely that the blood just pushed down on the brain stem, compressed the reticular activating system, put the patient into a coma, and the patient died. You okay with this? There's several more. Okay, people. Okay. Spoiler alert. There are going to be more bloody slides. So if you're really queasy about blood, do you want me to warn you? Because everybody says they're not. And then about 6 years ago, someone sitting in the front row fainted on the floor. So I'm serious. I don't want to. No? We're good? March on. Okay, so maybe it's just you. Put something there padded. So if you land there, you won't bounce on the floor. And this one matches very similarly to this. This is exactly what it would look like. And obviously, both of these ended up being fatal. So that's exactly what it looks like in the brain. Dark substance in the brain is blood. White substance on the CT scan is blood. It matches just absolutely perfectly. Okay? Here's an evolution from the acute bleed, just happened in the emergency room. And then what happens is they get edema around it. So right now, there's no big pressure. In other words, this hemisphere has not been pushed this way. It's in the midline. Notice what's happened 3 days after. There's a lot of edema. It's now compressing the brain. It's pushing it across the midline. And at 9 days, there's still a lot of edema. And you can see there's a big shift. And that shift is bad because that's what puts you into a coma. And you just have to, if you're not going to do surgery to try to take the clot out, you got to be really aggressive in your medical management of the elevated intracranial pressure, because it will eventually go down because the blood will be resorbed. So this is a neurological medical management issue. And this is what it looks like 14 months post. You can see this is where this massive hemorrhage was, right? Massive, almost killed the person. The docs kept them alive. And you can see all that's left here is this slit, little slit. And it's damaged the tissue right around it. So you can see, it used to be, when I started my residency, people said, oh, the person has an intracranial hemorrhage from hypertension, they're going to die. Well, guess what? It's not true. You need to be, for those of you who go down this route, you need to be really aggressive. And you could save the patient. And, this patient is alive and walking around with some residual deficits, but alive. So now let's switch to another kind of popped blood vessel. And this is not related to bad behavior. Not bad behavior is not the right thing, because everybody does whatever. But, risk factors you can control. This is what's called an arterial venous malformation. These things are random and genetic. Anybody can get these. They're probably at post-mortem seen in 1 in 200 people who don't even know they have one. They're higher in Hispanic populations. There's actually a gene in Hispanic populations that puts you at risk for these vascular malformations. So what's a vascular malformation? What it is, normally what should happen is, this is a cartoonish view of this. Here's your artery, right? Blood flow's coming in. It ends up in a capillary phase. You extract your oxygen, etc. It goes into the venous phase. And it drains out, goes back to the heart, and then the whole thing goes over and over and over again. That's normal. In someone with an arteriovenous malformation, what happens is, instead of going to the capillary phase, they end up with a disorganized, worm-like looking malformation of the blood vessels, the arterial venous malformation. And because these are abnormal, they're not very strong, and they are predisposed to rupture. And the rupture rate, if you detect somebody, we detected one in our MR scanner in a research volunteer, we would immediately refer them, not for emergency things, but let's say we see an AVM in the right frontal lobe in an undergrad as a volunteer. Basically, you need to, the risk factor of that bleeding is 2% a year. So if you live to be 70, you guys can do the math. You've got a good chance of having this thing bleed. So we would refer it to be evaluated for ablation so that your risk is gone. Okay? Genetic. Arterial venous malformations. You can see that ball of abnormal blood vessels there. And they're weak. They're weak walls, so they're likely to pop. The other genetic abnormality you get that leads to hemorrhagic strokes, and in this country there's roughly 30 to 40,000 a year. And unfortunately, a lot of them are not recognized soon enough, and the mortality right now is about, I'd have to look again, it's about 50 to 60%. And sometimes it's because the people come into the emergency room saying, I've got the worst headache of my life, and they're diagnosed as a migraine, when in fact they've had a blood leak, either from an AVM or from an aneurysm. And we'll get into what you should do in a minute. But again, here's your circle of Willis. Remember Willis, the guy in 1690, at the beginning of the course, the kid with the abnormal brain, and that changed the whole field, the brain-made behavior. He also described the circle of Willis. And we all have it. We all have the same thing. This is your basilar artery, which comes up through your cervical area. And these are your posterior cerebrals going to your occipital cortex. Here's your big middle cerebral coming up and going to your internal carotid coming up into a middle cerebral artery, going up to do most of the hemisphere. And then there's a connector that then produces the anterior cerebral. So you have anterior cerebral, middle cerebral, and posterior cerebral. They're all connected by these connecting little channels, little blood vessels, and this is called the circle of Willis. Now, there's a lot of we could talk about this forever, but the main thing I want you to remember is wherever there's a junction, wherever there's kind of a right angle, there's a tendency to produce outpouchings, just like the outpouching on the inner tube, just like the outpouching, the weak wall from the chronic hypertension pounding away at your little penetrating arteries. But this is genetic, and it sits there, and it's a time bomb. Because if it ruptures, what I just told you, if it has a severe rupture, it's got about a 60 to 70% morbidity, mortality, which is a lot. This is what it looks like. There's a bury aneurysm. If you had someone come in, they're at the Tang Center, they're pumping iron, and they said, my head, they collapse. They're out of it. They're brought into the emergency room. The first thing you're going to think is that they ruptured an aneurysm. Yeah. Yeah, that's where the aneurysms form. They tend to form at junctions. Like this is forming right in this area here. This is another spot to form them. This is another spot to form them. It's just that when things take their little turns, they're a little more liable to have a weak wall. And what happens is you basically have an outpouching. Just think of this as an inner tube. There's the outpouching, and here's a bury aneurysm because it looks like a bury. And they can be anywhere from 3 millimeters, 2 millimeters, to actually up to 3-4 centimeters, depending on the particular case. And if they rupture, what you want to do, if someone comes in with those symptoms, acute onset, severe headache, and you don't think you think it may be a bury aneurysm, maybe their neck is stiff because they've got blood irritating their meninges, you need to get them right to get a CT, see if there's blood, do a spinal tap, confirm there's blood, and then they go to angiography. You define whether there's an aneurysm, and you get a surgeon involved to fix it. Because if you do, you have a tremendous outcome of bury aneurysms. If you send them home and you say it's a migraine, they may have a second leak, and the second leak is almost invariably fatal. So detection of the first leak in the emergency room is absolutely critical. So here's an example of some on an angiogram. This would be a lateral view. I've injected the carotid, and there's a bury aneurysm. It shouldn't be there. That one's even got a little nubbin on it, which means it's even more likely to rupture. Here's another one here on an AP view, and you can just see the artery coming up and a big middle cerebral artery aneurysm. They need to be treated. Things that put you at risk for these AVMs rupturing that you don't know you have, and aneurysms rupturing that you don't have, are things that transiently increase your blood pressure. Catecholamines, amphetamines, cocaine, good dose, drive your blood pressure up. Sometimes just the act of heavy weightlifting, where you get about a 40% increase in your diastolic as you're doing that, doing your weightlifting. The other thing that can rupture aneurysms is during orgasm, because during orgasm, people's blood pressure goes up 30 points, and you see patients who, during orgasm, have a severe headache, and they've ruptured an aneurysm. Sometimes it's just a coital headache, which is not serious. It's not fun to have, but it's not fatal. But some are actually an aneurysm. I had a case at Highland years ago. I was on call on a Sunday. They said there was one of the doctors in the area was making love with his wife Sunday morning, and he said, "Oh, my head!" He collapsed, and he was in a coma. I went in and saw him. He'd actually had a carotid artery aneurysm, and when it ruptured, it actually transected his brainstem. So he was going to die. But this was a classic example of a rise in blood pressure from many different things. Okay, so the symptoms are a stiff neck. You have bad headache, and if the patient's laying in bed, normally I can raise their head. When you try to raise their head, they go, ouch. That's because blood is an irritant to your meninges. Doesn't matter where the blood comes from. Trauma, ruptured aneurysm, ruptured AVM, stiff neck. And then when you take blood out, you do a spinal tap, you'll actually see evidence of blood in the spinal fluid. And it could be acute blood, or it could be there for a while. They had the aneurysm 4 days ago, and it's already turned a little yellowish, the coloring. Or it could be not real. It means you got a little blood on the start of the spinal tap because you hit a vessel, but it slowly clears. So that's a traumatic tap, no problem. That's an aneurysm. That's an aneurysm that's happened days before. So these are very important, and then you have to act urgently. I can't stress that enough, because if you don't, this is a subarachnoid hemorrhage, on an actual CT scan. All that is blood in the subarachnoid space from a ruptured buried aneurysm. And if you don't effectively treat the person, this is what happens. You die. The patient dies. That's a fatal subarachnoid hemorrhage. You can see everything there that looks nasty is nasty. It's blood completely covering the brain, and your brain can't tolerate that. So this is your job, not your job, but you don't want this to happen, obviously. So you need to know about it, and you need to deal with it. 2 ways to deal with it, and then we'll stop real quick, just so you know. The surgeons can actually do magic, put a clip on the buried aneurysm so that it's clipped, and that's it. It's not going to rupture again. If the patient's grade 1, they've only had a headache and a stiff neck, you clip it, they're fine for the rest of their life. You've prevented them from having a second leak, which is often fatal. And then the procedure that I really like, which is new and requires less surgery, is the DiGuglielmo coil. This is one of my favorite advances. You have an aneurysm, and this guy DiGuglielmo, and I'll tell you more about him next class, he put in a grant, which everybody thought was crazy. I didn't, because he sent in some pictures were amazing. He said, I can thread a catheter into the aneurysm, no surgery. And the catheter has platinum in it. I'll pass current through it when I get it all in the coil. So I've got it. Here's the aneurysm. I put my coil in there. I pass current through, and I clot it off the aneurysm without any surgery. It's absolutely remarkable. And anytime you can coil an aneurysm, you're going to, because then you don't have to open up the head. Sometimes you have to, but sometimes you don't. What? It basically is, it's almost like you got magnesium and you get enough current. It's like you're making it burn. It's the platinum's at a certain state that current makes it heat up. That's basically it. You're just heating up the tissue. It's a thermal coagulation. Right. Thermal coagulation by putting current into the platinum. So this is a remarkable development. So let's just stop there. You should have a good feel from stroke. Remember, if you're at dinner, Grandpa says, I'm having trouble speaking, my right hand's weak, take him to the emergency room.